So, good morning, everybody. So we have the first live case session today with me. My co-chair is Satoru Otsuji from Japan.
Good morning.
So we will have a live case session from the Minneapolis Heart Institute with Dr. Emmanouil Brilakis and Dr. Allana. So I hope the line is already open to Minneapolis.
Good morning, and thanks for having us. It's a great pleasure to show you our case. First, let me introduce our team. Next to me is Dr. Salman Allana, who is finishing his CTO training right now and going to UT Southwestern for next year. Then we have a very experienced team, done a lot of CTOs together. We have Cam, we have John, Essie, and Kayla on the control room. And again, we're very honored and thrilled to be with you today.
Yeah, thank you very much, Manu. So, with me, the co-chair is Dr. Satoru Otsuji. And we have quite a lot of panelists as well. I'm not going through all the names, Manus, just because the patient is already on the table. And please go on with your case.
Wonderful. Thanks again. Yeah, thanks again, Kambis and Satoru. So let's present the case. So, Salman, if you don't mind.
Yeah. Can you see the slides okay?
Yeah, we can see the slide set.
Great. So we have a case, interesting case of a 43-year-old male who has a typical CCS class 2 angina, and he's having exertional chest pain now for the past 6 months, which has been worsening slightly. He actually is a very functional person, but over the past couple of months, has been only being able to walk about 50 to 75 feet with chest pain and dyspnea and lightheadedness. No prior bypass, PCI, or MI. Next slide, please. His past medical history is significant for dyslipidemia and family history of premature coronary artery disease. He's a former smoker, but quit in 2004. As you mentioned, he has CCS class 2 angina on maximally tolerated doses of amlodipine, metoprolol, and isosorbide mononitrate. Next slide. He had an echo that showed normal left ventricular systolic function with no significant valvular abnormalities. He had a stress echocardiogram during which he exercised for about 9 minutes on Bruce protocol with development of ischemic 2 millimeter SC segment ST depressions along with chest pain with exercise. And on the echo, he had exercise-induced wall motion abnormalities involving the apical lateral, mid-enterolateral, and mid-inferolateral myocardial segments with a treadmill score of 5. So he was subsequently referred for a coronary angiogram, which was done at the RC hospital. Let's just move to the coronary angiogram. So as you can see, the left coronary angiogram, there are some collaterals to the right coronary artery. There is appears to be some moderate disease in the proximal LAD. There's also another branching vessel that fills in late, appears to be either a ramus or a high OM or a high diag, which is not clarified on the angiograms that were done. Next slide. Another angiogram, you can see good collaterals. Again, you can see the proximal LAD disease and septal connections to the right coronary artery and some epicardial to the RV marginal. Next slide. And that's right coronary artery that's occluded proximally. Appears to be a blunt on some RAO view, appears to be a little ambiguous proximal cap with a lot of bridging collaterals. So he was actually referred for CTO of the right coronary artery, but looking at the angiograms, we also decided to evaluate further the branching artery that was on the left coronary circulation and also assess the proximal LAD. I'll now turn it over to the panel as to what they think would be the right strategy.
Oh, thanks a lot for introducing the case. Very interesting case with a double CTO, actually. It's quite interesting that the referrals are so sure that all the symptoms came from the RCA. As we know, sometimes those branches, right, like diagonal branches, functional in terms of LV mass, can be even more important than the RCA in comparison to the ischemic area. So, Satoru, I mean, what would be your approach to decide which vessel to treat, or in these scenarios, would you go for both vessels?
First, I would like to treat the RCA.
Yeah. Technically, it seems to be easier, right?
Yeah.
And afterwards, and then how to proceed? Just to make a clinical follow-up?
Yeah. I would like the clinical follow-up because the territory is not too big.
Let's get the CMB, whatever.
Okay, Dr. Woong, how would you proceed? So, as well, going for the RCA first, and then making clinical follow-up, or evaluate the diag branch or intermediate branch as well?
Look at a 3.5 balloon, 3.5 by 20, and 2 by 20.
Okay, Manus, just let us know what's your plan.
Perfect. So actually, let me show you our pictures from today, because it's fascinating when you do the dual injections with the large guide cutters. You can see things that you don't necessarily see when you are doing the outside angiogram. So this is from today. This is the dual injection. Again, now, actually, this looks a little more straightforward. I mean, straightforward. There's still ambiguity in the proximal cap. You see the RCA has all these little branches coming off at the proximal cap. But the occlusion length, which we thought was going to be very long, actually, and turns out it's not that long, because we're reconstituting at the mid-RCA. But we're reconstituting at the bifurcation of a marginal and the distal RCA. So this is a big marginal. I don't want to lose that marginal. As we've discussed several times, these marginals can be a problem if we lose them. So I want to make everything I can to preserve that one. Then if we look on the left system, we see there's some disease in the LAD that looks moderate in this view. There is extra branch filling up late that, as you heard, actually was not called on the diagnostic angiogram, but clearly that's a fairly large vessel supplying the lateral wall. And it's not quite clear in this picture where this branch is coming from, whether it is a ramus, whether it's a diagonal, whether it's an obtuse marginal. And then this is a different projection. This is the RAO caudal projection. And as you can see, once again, we can see this branch on the left, on the lateral wall, to feel a little bit better. So we do have this branching vessel, also bifurcation distal cap. Still unclear where it's coming from. We don't see a diagonal. We don't see a obtuse marginal. However, it is going up with systole. So this tells me it's on the lateral wall. So it's going to be either, again, a high OM or a low diagonal. And then continuing to the pictures, this is a caudal picture, but we're trying to use this to understand the ambiguity on the proximal cap of this diagonal slash MCTO, but you can see it's pretty hard to tell. There may be a little vessel coming off as a ramus that may be occluded, but still not very clear. And then here's again another thing. Now here, the LAD, that didn't seem to be that bad on the other view, seems to be a little more affected, the proximal to mid LAD at the takeoff of the septal and this diagonal branch. So at this point, I don't know if you can you show them the pressure wire, please? So, Kambis, I don't know if you can see our pressure wire. So we ended up doing a pressure wire on the LAD because we're just concerned, are we missing something? And because, just to clarify, our first target vessel, as Satoru mentioned, is going to be the RCA. And because there's ambiguity of the proximal cap, we may have to go a primary retrograde approach and want to make sure the proximal LAD is in good shape, because otherwise bad ischemia could happen. And to our surprise, actually, or to some surprise, the IFR or DPR, this is the option system, was 0.73 with a big step up right where the diagonal slash septal are coming off. So we do have significant disease into the LAD, in addition to the CTO of the right and to the CTO of the marginal vessel. So I don't know if that changes your approach at this point.
Well, yeah. So I think there's clearly significant, even if the vessels would be open, I think still this is a clear significant stenosis in terms of physiological assessment of the LAD as well. So you're dealing now with a free vessel disease, Manus, right? With preserved
Correct.
LV function, and medical therapy failed.
Correct. Very symptomatic, highly symptomatic. Obviously, the stress test is positive and everything. Can you get a new wire, please? Give us a C on black. Yeah, highly symptomatic. Now, you can make an argument for surgery as well. But having said that, 43-year-old with surgery, that's probably going to be a little on the early side. He's not a diabetic. And So our plan remains to do percutaneous coronary intervention. You can see the LED is fairly tortuous. Took a while to get the pressure wire, but eventually we were there. So we're still, in our plan is to fix to do PCI. We decided to stent the LAD first before going retrograde because we don't want to get into hemodynamic instability. It was actually interesting that we did have a lot of, the pressure went down, just a 10-second inflation, pressure went down, putting the stent in the LAD, massive EKG changes. So clearly he depends on the LAD significantly. So it's a good thing we did this, but now he's doing well. So our plan here is to get back into the LAD after we've stented it. So this was before the stent. This is just some predilatation. This is a 3.0 by 35 millimeter or zero. We decided to use or zero because it's a little thinner strut, so a little easier to get into this septal branch. And this is the picture after the zero is in. We did an IVUS. I don't know if you can show them the IVUS, please. And we're a little underexpanded, but I want to wire first my septal, and then we'll do a balloon inflation, kissing balloon inflation, and then our plan is to go with the primary retrograde approach.
Can I ask you the strategy to stent the LED? I mean, and you didn't protect the septal branch. What if you, after stenting the LED, and you lose your septal branch, so you're going to lose your retrograde access? I mean, did you take this into consideration, or you just
Yeah, that's an excellent point. We did think about it, and we did discuss about it. We thought there was not really much disease on that septal branch, and it was very unlikely to do so. But you're right. I mean, nothing would have been lost by putting a pressure wire into that septal. So it's a great point. A little pass there, please.
So, Manus, what makes you thinking that retrograde first is the best strategy here without trying any antegrade approach? So,
3 or 15 balloon.
What makes you, let's say, skeptical about antegrade vasculation as primary approach?
Yeah, great point. So something actually I didn't show you, but we did try to, we put this wire that went into this small, it's a small, essentially atrial branch. And then we tried to do IVUS to see if we can clarify the ambiguity. IVUS wouldn't deliver. Tried to put a 2 balloon there, balloon wouldn't deliver. And to be honest, this concerns me. I mean, this RCA, and we do have separate views. Here's another one. So this RCA concerns, because if you look at this, there's so many little branches coming up.
Okay.
Now, I could, so I don't have any clear target. I cannot do IVUS in any of those branches yet. Multiple branches, and I don't want to dissect, because if I dissect, there's a good chance we may lose this acute marginal branch, which I think is very important.
Okay, so your strategy will be retrograde and then retrograde knuckle or let's say a retrograde marker to know where you puncture antegradally, because you're not sure about the antegrade cap, right?
Correct.
Okay.
So I'm planning to go all the way back,
yeah,
and then use this retrograde as a marker of where to go.
So this is now a dual lumen microcatheter, which is very useful, right? Because you ensure that you are not behind the struts.
Yeah, so most of the time when I'm trying to wire through a recently deployed stent, I like the dual lumen, because otherwise, as you know, if you accidentally wire on the side, you may crush the stent, create a lot of problems. So I really am a big proponent of using a dual lumen microcatheter. It was a Suzuki. And that was a Sion Black going into this septal.
So when you do pre-PCI IVUS, did you see the origin of occluded diagonal branch by any chance? Because from the angiogram, we didn't know what where the diagonal branch is coming from.
Yeah, we did the IVUS of the lady. Actually, let me show this to you. Do you mind, Chris, if you can show it up there? So yes, can you please, actually that's the previous one. Go to the previous one. Let's show the IVUS of the LAD. So that's an excellent point, because you're right. If it was a diagonal branch, you don't want to jail it before you have a chance to take care of the problem. So this is the IVUS of the LAD. Let's play this. Open. The previous one. There you go. Perfect. So maybe just let it play for now, and then we'll see. And actually, this eye was, was done after the pressure wire, so we kind of knew what was going on. You can see there is some plaque there, and we're coming back towards the diagonal branch. Yeah, 150. And you can see here quite a bit of plaque. Looks like there's some shadowing, but I don't really see much calcium. It looks more like lipid-laden plaque to me. And then we're coming back. Again, this is the left main. This is this little branch that could be the CER, could be a small ramus, and there's the left main, and we have some disease. So I didn't see any occluded vessel coming out anywhere in the LAD, and that is why we decided to stent it. Okay, so 1 second. Let's.
So you think the occluded vessel is OM?
I think it's going to be a ramus, but we need to take my plan. My plan to find out is to actually put a microcatheter inside this little branch, I think is the ramus, and then do an injection to the microcatheter and with the other vessel as well. So again, a little more things to learn. Can you get a towel, please? Give me a towel. They will do kissing balloon inflation, again, 3.5 on the LAD and 2.0 into the septal. And this is going to be the septal, the top is the LAD. Yeah, so my plan right now is I'm going to post-dilate that LAD and can make sure we have good flow.
3.5 non-compliant, John. 3.5.
3.5/20
non-compliant.
and then 2.0/20. And then after doing that, then I'll go retrograde and then use that, as Kambis was saying, use that as potential marker of where my vessel is.
Great. Compliant, okay.
That's fine.
Yeah.
So, Dr. Habara, in terms of the antigrade preparation, what would be your choice here? You have seen the the Volcano Ivers could not pass. So, what alternative could you give us as advice in such scenarios?
Yeah, so that's so in this situation, so
LED.
It's the
LED, right?
entry of
It's
the
the
CTO
is
to
the,
be detected is
is
very
the two.
important. So that's so
3.5.
if I were operator, I will do the so chip injection as so near the entry, and so maybe the so rotation angle or something will be happen, and check the so the angiographical entry could be detected or not. If it could be detected, so antigrade will be performed at first. But also, this is a very tiny branch, and so if possible, so one choice is also retrograde approach because also septal branch is also interventional and so not be so bad. Yeah.
Because of the good opportunity of the retrograde access over the septum. Yeah.
Yeah, and so this style of the so CTO exit is also looks tapered.
Any chance with a more low profile IVUS?
Yes, maybe so. Anterior could be pass.
Yeah, so actually we do have also the Boston IVUS, but somehow today it's not been functioning well, so that's why we use the Volcano. But you're right, the Boston IVUS is much more likely to cross through more tortuous and smaller vessels as well.
Okay, now you have a 2.0 balloon here.
Correct, so that's a 2.0 into the septal, and I'm going, this is again a 3.5 into the LAD. Let's go up there, 10-12.
Yeah, got there, 12.
And again, I don't know about you, but it's always delayed. I recently had it down. I recently had a case where we got a microcatheter stuck through the struts of a previous stent. So since then, we've been extremely careful to always dilate through the struts of the LAD, the donor vessel, so we don't get similar problems down the line.
And the
get the microcatheter. I'm going to put this for
3.5 you can
trapping.
use for trapping in the microcatheter,
That's right.
right?
That's right.
Let's
Let's go up there. 15.
Emmanouil, do you usually kissing balloon in this situation?
Can I get the microcatheter?
Manus,
I mean,
Yeah,
you
Manus-
don't have to do it, but the LAD is an important vessel, right? So I think once you balloon into the side branch, what you do is you disrupt the main vessel. And again, here our concern is ischemia, right? And the eye was showed maybe slide under expansion of the LAD stent. So that's why I wanted to make sure I expand the LAD stent well, and I don't have any deformation of the stent. Trapper is up?
Trap, yep.
Can I
so
just
there's
ask?
So,
one
but yeah, you
comment.
don't have to.
There's
I'm
one-
not sure whether it was discussed. Anybody concerned about doing an FFR, the value, correct value of the FFR when there is a significant collaterals to the RCA? Yeah.
Well, you know, actually, we know that after opening the CTO's FFR might increase, but already resting gradients
Get
was
it.
already
Let's see.
0.73.
get this.
So
Let's take a
very
look.
unlikely that you might have a normal
This is the Xeon Black.
LAD after
3cc
opening
and a Xeon black.
the RCA and the intermediate branch.
So that was a resting gradient.
It was a DPR at the 0.73.
So IFR is 0.73, yeah. So there's no way it's going to get back to normal even after we fix the
Highly
lady. But that's a great point, though.
yeah.
Yeah, it's a great point because that could happen. If it was a little higher, then that could definitely happen. And then typically we serve here immediately, but here because there's multiple little branches, I will do a tip injection in the septal just to get a sense of whether we're connecting and how we're connecting there. And this is a turnpike, again, it's a turnpike LP 150. Okay, let's get the Xeon Black. Let's get a little saline, please.
The 3cc for Cheol.
So there is this branch that connects more towards the apex. There's a few other branches. Again, not the best in the world, I would say, but we'll give them a try.
Sure. So now you are directly going with the black, Xeon Black, as a polymer jacket wire?
Correct.
Right? Okay.
Correct.
Do you always choose to go to the largest septal for your contralaterals? Because the connection seems to be better in the distal septal branch. So,
Yeah, good point. No, we don't. We just use, whichever brand seems to be the best. Here, it was a little further down. Now, the downside of having going through the stand is that you have to go through the stand, which we wouldn't have to do on the other side, but we'll have a low threshold for switching to the other one if we have difficulty over here. Which it looks like we do have to some extent.
Don't have SUO3 ready.
Yeah, let's get a SUO3 and let's...
There you go.
Yeah,
No.
this is some right
No,
marginal branch.
that went
right?
out. That went out.
That went to the epicardial.
Yeah, let's get the SUO3.
SUO3.
Didn't you use torque devices to control wire direction? Brilakis? The dedicated,
For surfing?
delicate control is needed. I think that so. Why don't you use torque
Yeah,
device?
great point. To be honest, I almost never use torque because the big thing for surfing is to have big movements and be able to spin the wire a lot. And with a torque, you cannot really spin the wire very much. So for surfing, I almost never use a torque. I just use the finger, so then you can spin it a little faster, and you don't have to worry about not spinning fast enough. But again, I mean, there are different ways to get this done. Again, we'll switch to a SUO3. Again, it's pretty tortuous from what we've seen. But we have a low threshold. If in the next 3-4 minutes we cannot cross, then we're going to the more distal septal, which, as you said, seems to be maybe connecting a little better with the PDA.
What wire are you using now?
SUO3.
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 Yeah, so we switch to a little more gentle. I think it's quite tortuous. Let's go back. Excuse me for a second. Let's go back.
I
So, as
usually
you've seen,
use audio caudal projection. How about the Kambis?
Yeah, the same. RAO 0 because a little bit less radiation and or a little bit caudal.
yeah, we can go more at AO. It's more towards the base where we'll have the issues.
And I think the second septal is much easier than
No, actually,
the first septal.
it depends what you want to see. The best projection for the engaging and
Let's get a
might
little
be
picture
cranial,
here.
Yeah.
but the best injection for
On the
going to the
left.
PDA might be caudal.
Yeah, yeah.
And so a compromise is, very nice.
Oh, very nice.
So your suggestion, let's wait for a second, sorry. Your suggestion was very good about the going a little more RAO. Okay, pressure was good. All right, let's take it there, gentlemen. All right, good.
Nice.
All right, so that looks good.
Absolutely.
So I'll move it up as far as it goes. You see, it's so close. I mean, it's teasing us almost, but. And then we'll see sometimes those calls can be a little tricky to, but you know, see, I'm not even turning, I'm just advancing. This is a turnpike LP again, and just, it's going no problem.
Great. Even without rotation, right? Perfect.
Yeah, I'm not rotating, I'm just, just gently
good,
pushing
it's
it up, and it's going up there. And then what wire would you suggest I use over here? I'm thinking for a guy next, but look at the syringe for tip injection. But open to any suggestions.
Yeah, so you're going to do a deep injection, right?
That's right. Actually, let's do a dual. Let's do a dual on the right.
And
do the
probably
tip injection
decide
at the same
after the
time.
deep injection. I mean, if you might have some kind of a tapered retrograde stump, maybe even a softer wire is possible. Polymer check it as well.
Okay,
We'll
wait,
see.
I'll tell you when, okay? Wait. Okay, go.
Well,
It is tapered. There is a small branch
so
coming up over there, but I'm not sure that the polymer will work here.
yeah.
Can
So
I get a
I personally, Manus, but it's only I would have because it's on the table. I personally would have a very short try with the Sion Black because it's on the table. Sometimes you might be wondering. But if then you feel
Yeah,
immediately
that's a great point. Nothing to
if
lose.
there is some resistance, if you feel resistance, and even the Sion Black, you could, if it creates a small knuckle, also not a big problem because then you have a clear target for your
Sion Black.
antegrade wire. So it's a good compromise
the
if it's on the
previous
table.
Yeah, no, I completely agree with you. Again, nothing to lose going softer than harder.
Okay, Miss, did
Again,
you,
it is
do you
fairly
try
short,
the
as you've
retrograde
seen.
in this situation with Sion Black?
Yeah.
No. Yeah.
Yeah.
Okay.
Yeah,
I agree.
Yeah, because
Yeah.
already on the table, you know,
Yeah.
and good option.
But the Sion Black may be broken.
Yeah,
The
but
first attempt.
These are going up.
yeah, maybe. We'll see. I mean, only you get some tactile feedback. You see if there is some resistance or not, and also some polymer check it. Even if it makes a very small knuckle, you have a target for your antegrade as
Yes,
well.
yes, thanks.
So I think it's a reasonable option here. So you see, and almost here at this point, probably going to the extra plaque. But maybe now he can check on prepare a little bit more the antegrade. You see, Manus, the wire is deviating at this point. Very good. RAO was very
Yeah,
important.
it's going into a small branch there. So let's get a guy on next to, please.
So if you have the impression it's not puncturing, probably what you're doing is step up, right?
Correct.
To
So
a
I'm
more
actually
penetrative
getting
wire.
a guy on next to.
Exactly. Yeah. So I mean, gave us additional information to explore that because that was not visible, that branch, and at this point probably it's really completely blocked. So he has to penetrate now this distal cap, taking a guy a second next.
Yeah, actually the RAO view was very useful here because in the LAO it was hard to tell what was going on, but in the RAO it was clearly going into a side branch. So a little more penetrating.
Very nice. Already penetrated the cap.
Now it's going in the wrong direction.
Some branch. Go into some branch.
Yeah, maybe he's cross-checking now in the other projection.
Yeah, going to the LAO just to make sure. Again, you can see it's very confusing here because even the undergrade wire, it's in a branch. I mean, it's hard for me to tell whether it's in the right branch or not. In the meantime, one of the source of concern is his STs are a little up, so I wonder if he's still ischemic, so I need to get this moving fairly quickly to relieve the retrograde system.
But you think there is some ischemia now, or no? Huh?
There is some ischemia. I mean, again, the STs are going up a little bit.
Okay.
But I don't know if this is from the LAD, from having the catheters into the myocardium in the LAD, which is standard,
Yeah,
but still.
You retrieved a little bit the
Or
antegrade guide.
if it is coming from somewhere else.
Yeah, you retrieved a little bit the guide as well, so I think it should be no problem. So maybe...
Take a picture there on the right, a little picture on the right.
Are you going to somehow prepare now the antegrade cap, or what's your plan, Manus?
Yeah, I am. Actually, what I'm thinking to do here is I'm trying, maybe I go undergrade, because the retrograde is not going places I like. So what I'm thinking is get an undergrade wire and try to go for, use the retrograde as a marker where to go. Can I get another Gaia next to for the undergrade?
So, because this can work nicely, right? The retrograde marker wire, and even
135,
probably you can
Exactly.
pass it antegradely
Exactly.
as well with the kissing
And we're
wire
so
technique.
close now. And then I get a 135,
135, yeah.
Corsair, please.
Corsair.
Maybe the proximal cap is very hard, so the retrograde slip the subinterval space. So it's time to integrate.
Yeah.
To target the retrograde wire.
So, Satoru, do you have in these situations? Do you always have
You don't want
CT?
excess, right?
CT
yeah.
available?
Yeah.
No, just a second.
Regular.
The CT
Corsair
is
Pro.
not always useful. Sometimes the very small calcium, we cannot see the CT.
Yeah, actually, we discussed about this. CT would have been extremely useful here. I think for the, not as much for the right, but
Corsair.
Corsair. For just excess is fine, do whatever you have. But especially for the lateral wall vessel, that would have been very useful to understand where this is coming from.
Yeah. Any comments from the panel regarding the strategy? So, Dr. Chan?
I totally agree.
Probably prepare the integrate, probably just go some dissection for the reverse cut. I would do it at this stage, because I don't think that the retrograde wire is able to penetrate the cap. So I would just go for reverse cut at this point.
Yeah. So, Dr. Chan, you wanted to say something?
Yeah. Reference for the retrograde wire, I like to approach integrate wire. Yeah.
And the first would be try the kissing wire technique?
Yes. All right.
Because wires have very nice overlaying, right? We're very close.
I'd like to ask a question to Dr. Mahara. Previous your lecture, you show us a penetration plan method. Yeah. What do you think about this method in this situation? How about your Canon workplace?
Yeah. So if that's what we use, so we can use ECG synchronized system. So this situation is very useful to use penetration plan method because there is a marker of the wire.
Okay, I got it.
So Manus, I have to ask you, you're working with 2 8 French guides and femoral. So do you use the radial as well in your cases, or I mean
we do. Sorry.
I mean it's clear data out there, right? That we can reduce a little bit the bleeding complications on the radial.
That's right. So actually, our most common access strategy right now is femoral and radial.
Okay.
1 each. The reason we went by femoral here is there was a very small radial, And we didn't think it was going to fit our seven friends guide. So that's why I went by femoral. But you're right. The most common access strategy right now is radial and femoral. I don't know, how about you? How about in Korea or in your labs? Are you doing similar thing or by radial or?
So maybe we can ask the panel. So who's going to, yeah?
For the very simple CTO, radial and femoral. But in some complex case or some need for the radial approach, was femoral.
Femoral.
Right.
No, I
give us a
tried
Xeon Black.
one femoral and one radial. Because we have the thin Cs.
Yeah.
So we can use
Give me
6
actually
French Cs,
give me an XTA.
but a 7 French guide.
We almost changed our practice to the B radial. Right? Yeah. Yeah.
Really?
Yeah. Because a patient can go home, right?
Yeah.
Very so yeah, and you don't have to care about any femoral complications.
But if you use the IVAS guide, you have to use H French, right?
Not necessary. The Medtronic guide launcher can give you a 2-0 burr. You can place the Boston IVAS with a Corsair. The only reason I do the 8 French is almost ipsilateral scenarios with one guide. So let's say left dominant system. But I mean, it gives you for sure, like here with Manu's, a better support and it's very much comfortable. And
he uses now 8 French guide.
he has 2 8 French guides, and you see the proximal cap is very hard. Still has some backup problems there to penetrate proximal cap. So Manus, which wire is that now?
So I actually downgrade a little bit. This is a Fielder XTA.
Ah, okay. So what was your impression with the Gaia second? What was
and it just kicked our. See, we're dancing very close, and it just kicked us back. So I'm using this one. If it doesn't work, I'll go back to the Gaia next to. And then I'm probably going to put a guide extension in if I have, because I think part of the problem here is support.
Yeah.
You see, I'm very close, but and I'm going to pull the retrograde stuff a little bit so you can see it a little better.
The guiding system support looks weak.
Yeah. It's a AL1 or 0.75?
This is AL1.
AL1, yeah.
Let me get again the Gaia next to, please.
Gaia next to.
Yeah, so that cap, I guess, is on the harder side, but. All right. Yeah, and actually, you know, the thing for biradial also in the United States is that, you know, this patient is not the typical, but most patients have a BMI in the 30 plus range and often in the 40 range. So doing biradial means that you have to be very tall and have a very strong back because you have to lean, even with distal radial and even crossover still, it's a little challenging in terms of reaching over. So that's one of the challenges, I think, that maybe a little more specific to the US.
So this wire now changed to?
This is a Gaia next to.
Gaia next to again, yeah?
Yep. Okay, let's get a trap liner, 6 French trap liner.
In this situation, I want to change the guide because even though the wire passed the device, maybe I'm passed.
To AL2.
A2 or A1.5.
Or 1.5. But now the wire is very nice progress, and Manus is checking immediately contralateral side, so perpendicular view. So seems to be very good here, right? Even ready for tip-in.
It's dancing well. It's dancing well.
Already passed. Congratulations, Manus. Very nice.
Yeah, it's going to be interesting here. So as you see, the cap is going to be an issue. So what I'm going to do is, I'm going to advance this quite a little bit and then put with the guide extension in. Actually here, it may be worthwhile actually to externalize. I'm not sure actually this is true lumen, to be honest. The way it's behaving is not the best. So let's do this. Let's strap this out. Give us the 6 French strap liner. And then to a balloon to inch worm it in. And then I think I'm still going to externalize, I think, for support and
No, guide is
to be on the better side. 1
engaged,
second here.
right?
Let's inflate the trapper there. I'm sorry?
Oh, now guide is deeply engaged.
No.
Better than
No, it's
before.
better, yeah.
All right, let's get the trapper out, drop it down.
So just in interest, Manus, you don't wear any leads, right, below that? Manus, you don't have any?
No, I don't. Yeah, so this is the zero gravity system.
Yeah.
I'm wearing just a gown, like a surgeon. I'm not wearing lead. It is a 1 millimeter. It's a 1 millimeter diameter, so it's a thicker lead than the one you typically use when you use your fit-on lead. And I love it. Again, it's been several years now I'm using it. Again, it hangs from the ceiling, so I don't get any back pain. It takes, I would say, about a month to get used to. But once you get used to this, you never go back.
Okay.
I got it. You get a towel.
So
then,
even after long working,
it really works pretty well.
so even after a long working day, you don't feel tired, right?
That's right. No backache. It is dramatically better. Okay,
Great.
actually, I think this is a cross. But still. Now, there is the rampart system. As you know, many people now in the US especially are using the rampart more. Let's get a tuba balloon. Which is also you don't wear lead, although I guess there's always the concern, are you fully protected or not? So for this one, it's like wearing your own lead. You see it has this front part, so actually the radiation coming to your face is also deflected. So I feel very good about it, but again, many people find it a little cumbersome to use because of the difficulty getting used to it in the first place.
Yeah. So now what's going to be of interest is if we should put this lady with 42 years now on a full metal jacket, and because distal there were some disease, but probably the plain angioplasty is enough, right? So,
Let's inflate it.
what do you
Yeah, I
think,
mean, to be honest, you're right. I mean, we'll see how it looks after we after we predilate, but my sense is try to minimize the stent length here. It's actually a man, it's a 43-year-old man. But I mean, regardless, young person, you don't want to put a million stents there. I completely agree with you.
Yeah. But still, there seems to be some resistance on the proximal cap. Very likelihood that you have an intraplaque crossing there.
Yeah, wait, sorry.
Very high likelihood, yeah, for intraplaque crossing. So what's your guide? Yeah, great.
Want to take a sapphire?
Yeah, actually, 1 second. Let's do this. No, okay, give us sapphire, why not? Okay, so 1015, sapphire. All right, so balloon and crossover. So it's interesting, this seemed very calcified, at least angiographically, we didn't really see much, but it is behaving a little bit so. Now, I do feel a little better in terms of being intraplaque. I think I'm true lumen distally. It looks like I'm tracking the retrograde wire fairly closely. So I'm feeling good about my wire position. So actually curious, would people just externalize at this point to get the support or just balloon it? What would people do?
Yeah, so we can ask our panel, Dr. Fujimoto, what would your advice in this situation?
I choose more small balloon and after direction I check IBUS and I perform this CTO PCI bilateral radial approach. Recently, almost case of my procedure bilateral radial approach by 7 French. IBUS guide anti-grade approach can perform with terrible IBUS recently. So 7 phase is okay recently, PC to PCI, I think.
Okay, done.
How about the
how about give me a C on black?
Anchoring balloon is more better than the guide extension case?
Go retrograde, see if I can go retrograde.
The backup. 300 or?
Long, sure. 300 C on black?
300 C on black.
Even though we used, Dr. Brilakis used guide extension catheter, so I would like to better solution is anchor balloon. Yeah. About the anchor balloon.
Yeah, it's a great point. We don't use it as much. I know that in Eastern it's used quite a bit. There were some branches who could have used a trapping balloon, an anchor balloon. But here we thought we will try with this. But if it doesn't work, we can definitely do it. But I think at this point we're so close that we should be okay. But if we need to, there are some small branches that we can advance an anchoring balloon to them.
So you changed your retrograde wire now?
Yeah, I got the C on black, and see if I can just go the retrograde, get in the guide, and then externalize. I think that will be the solution, definitive solution to my problems in terms of support. And
okay,
again, might be a little tricky.
So have you been able already to dilate a little bit?
The Sapphire went not all the way, went just a little bit.
Okay.
So didn't make it all the way. That's why I gave up and went from this. It did make a little progress, but not as far as I would have liked it to do.
The guideline a little bit.
Let's get the gutsy line a little bit. Top liner, I mean.
Mm-hmm. Maybe another dilatation there, huh?
Yeah, the challenge there is, Kambis, that the balloon doesn't go there, so.
Here as well, okay. Okay.
Yeah, it went up to where my trap liner is, didn't go all the way. But give us another balloon, give us a 1.5 balloon, maybe that will, and you know what, let's put a little bigger band.
Yeah.
Let's do a different view. Yeah, I have a feeling I may be slightly extra plaque on the retrograde wire. Sometimes when you have small vessels like this, actually they can be your friend, but.
What about the specialized microcatheter, especially, for example, screw type turnpike microcatheter?
Turnpike spiral, you mean? Yeah. Spiral, yeah.
The spiral, retrograde, we don't use a spiral, right? So on the undergrade, we could.
I think
there's also something called the turnpike gold that has a metal tip and can sometimes be helpful. Let's get the balloon.
So for me, I try to advance the anti-grade wire a little bit further and try CTO balloon again. It might give us a better support.
For the balloon?
Waiting for the 1.5.
As well, good idea, yeah.
1.5, yep.
Yeah, no, absolutely. I mean, so, the algorithm for balloon uncrossable is the first thing we do is small balloon, then we're up through the balloon. So use a Sapphire, we use a 1.5. If it doesn't work, then I will get a different microcatheter. What you mentioned for the turnpike spiral gold would be a great option. If that doesn't work, then we can do the anchoring. And then if that doesn't work, then we'll have laser. That we can do, but it might be a little overkill, I think, for this.
Manus, how is your threshold for using laser, I mean, in the States? Because it's
fairly low.
Yeah.
Fairly low.
So that would be also very nice to see.
It takes 10 minutes to warm up. Can you actually bring the laser? Let's bring the laser and warm it up. So if it doesn't work, we can go into laser.
Because you already have nice anti-grade wire position and it's fibrotic. We don't see too much calcification, so it could be really a good option to bring the balloon in if you do a little bit of laser modification there, right?
Correct. I mean, it should be. This is actually a book, by the book approach using the laser here. If the other things don't work. Okay, no. All right, great. So let's do this. Next, turnpike spiral.
I mean, there are many options at this point, right? He even could
And then
go
get the laser in. Let's warm up the laser. If it doesn't work, let's do laser.
He even could go retrograde with a balloon and trap his anti-gravity wire. So because the septal is also big, right? But actually, the question is how to make the less complex scenario out of this here, right?
Because now we're going to other branches. So anyway.
So,
All right,
so
well,
I
you know, it's
thi-
funny. Sometimes you get
my
difficulties
gut
when you don't
feeling is
expect
I
it,
think
but-
we underestimate the severity of calcification at the proximal cap.
Maybe, yeah. Maybe you're right, yeah.
Yeah.
We'll see on Ibis then, yeah.
I'm sorry. I need.
It's okay.
Oh, okay. Actually, give me a pilot 200.
I think
in the
the
meantime.
little seems to advance
Long pilot 200.
previously created the
To get the balloon
lumen
to
by
1.5
Gaia second
for the spiral lumen?
retrogradely. So
They're getting done.
the chance
135.
is a little
So-
replacing is very little.
Low, yeah.
You want the, this is a pilot 200.
Do the spiral first. Or whatever you have ready. I will take this one.
It's not good. Yeah.
So this is now what, Manus?
So we are switching to turnpike spiral,
Okay.
and then I'm putting a retrograde pilot 200.
Okay.
You know, I was using a Xeon Black, and you know, the Xeon Black can be a little not as robust in terms of support. So by using a pilot 200, might have a little more penetrating capacity. So right now I'm playing on two different games, right? Either to go undergrade and cross it, crossable, or go retrograde and complete the connection and then externalize. So one of those two. And I've been mainly working on the undergrade. So now it's
I mean, the point is once you have a really absolutely balloon uncrossable lesion, it's very difficult to get the retrograde wire in the intraplaque, right? So
let's
for
go-
the,
let's go,
that's not so
Turnpike
easy.
spiral. Turnpike spiral.
correct.
So therefore, two options. One is that you give up wire position antegradally and you get, let's say, extra plaque with both wires, or you do the intraplaque preparation and ending up in some plaque modification like, laser or
And tell me if the
even
laser, when the laser is warmed up. Yeah.
or even some turnpike spiral gold just to modify a little bit to get a low profile balloon in, right?
Correct. Yeah, the turnpike gold, to be honest, we don't use that much because it's extremely bulky and it doesn't deliver very smoothly. So the spiral is actually a little better in that respect.
Yeah, I agree here. Actually goes perfect.
Going.
Yeah, very good.
All right, well, there you go.
Oh,
Let's
that's
get
fantastic.
the Minamo.
You want a stiff fire? Like,
Bummer, we're so excited to get the laser, but oh well.
Which
wanna
microcaster?
Xeon blue.
Turnpike spiral.
Oh,
Okay.
yeah.
Or Minamo, whatever.
Sure, yeah.
So now you change to an extra support wire, right?
Yeah.
Actually, I'll just use a Xeon blue for now.
Okay.
And then see how it goes. We could use a Grand Slam, that or a wiggle. The wiggle wire is the one we
Yeah. You
typically
wanna get
use
wiggle?
for this kind of. I don't know if you use it much. Has this extra bends,
Yeah.
and that kind of anchors the guide and makes it easier also to get through calcium if there is calcium for getting there.
It was a little
But I
bit
think once the microcaster goes through, in general. We should be okay, actually.
Yeah.
So I'm optimistic that things will deliver much better now. Let's get to a balloon next, please.
It was a little bit surprising, right? That the turnpike spiral just went so easily, right?
Well, the surprise is that the Sapphire probe, which usually works, didn't really do much. And the spiral did, but you know, again, the spiral has this mechanism of screwing into the lesion, which might be why this happened here.
I think this was really a good scenario for the spiral because you have some very small entry to the RCA, and I think the spiral already could had contact to the wall, right?
You know, I may have spoken too soon here.
There you go.
Yeah, there is some plaque
Unless
there.
there is a tight lesion there, or I am extra plaque.
Well, maybe check in another projection, right?
Yeah. And we didn't have any difficulty coming with the retrograde gear that direction.
You're good. You're good. I think it's just a plaque there, huh?
I hope. Yeah.
I'm not sure.
All right. How about this? Yeah, I'm not sure either. And I would hate to dissect all the way down there. So maybe I should just do a reverse card. Let's do a reverse card.
Go to the RV branch.
Yeah.
So how about the dilate the proximal part? Because the Sion blue already passed the RV branch. So I think the
so dilate the proximal
to 5 balloon and whatever you have, 2 to 5.
No. Dilate and proximal part and check IVAS whether the true or not.
Okay.
Because the Sion blue passed the RV branch.
Yeah. So the Sion blue passed the RV branch, Manus. That's why Dr. Otsuji is thinking about that you might be at a true lumen and it would confirm on IVAS after dilatation. So.
Yeah, no, I completely agree. But one option here is if we can get the retrograde, we know for sure it's going to be intraluminal, right? I mean, it was pretty smooth. So I think if we externalize at this point, that might drop down. That might be actually the simplest way, but you're right. I mean, there are many different things we can do here. So my current preference here would be to just do just a standard guide extension reverse card.
Okay.
But I mean, we'll see. Let's see how the balloons deliver. Okay, they deliver. Okay, go up there. 10, 15.
Okay, so you still want to externalize to also be sure for the retrograde, for the distal RCA and
I think
for
that will give us peace of mind.
Okay, yeah.
That we are in the right.
Okay, reasonable
in the
as
right
well.
location. I don't know, what do people think on the panel? Is that what you would do, or would you just try the undergrade approach? Go up there, please, then.
Yeah, we can ask this question, Dr. Chun. Would you go for externalization?
Yeah. Let me get it down.
Externalization is one of the options, but I think the integrated Y is probably in the intraplaque. So the Otsuji mentioned at dilate proximal lesion and check the IVUS and go if it's intraplaque and advanced integrated approach.
Yeah, let's do I'm pulling back. So we're doing the draft. You guys know the draft from Mauro. Carlino, just one person is pulling the balloon back. Let's inflate there. And down. Okay, you want to pull the balloon back?
This is the pilot 200
Let's get the balloon
on
down
retrograde?
and correct. This is a pilot 200. Okay, down. Take the balloon down again. Okay. How about you give me a Gaia? Let's go try with a Gaia next time.
In this situation, I would like
give us a
to
trio,
see
actually.
IVAS because I make sure the little wire is the same lumen or not.
Okay, that's not a bad idea. Actually, we can do IVAS there. I guess we're clearly going in the wrong space there.
Oh, I like change the pilot to
or the dilate
Gaia
more proximally.
So
give us this
integrated
to
and
5. How big is
retrograde
this balloon?
wire is
Inflate?
there seems to be
Let's get
different
the,
spacing. So
5
IVAS is
To 5.
crucial. I think that in this situation, so connecting point. is important.
Is it possible for you to advance the guide extension further down?
No, unfortunately, it gets stuck. It's still, despite, give us a 2.5 balloon, despite 2.520.
Dr. Brilakis, why don't you change
that's
your
how far I can take
retroid
it,
wire?
It still gets stuck there.
I think your retroid wire is not operable. Yeah.
So I think that so in this situation, so externalization of the retrograde is one choice, but also another choice is also a little bit also pull back the so retrograde microcatheter and also check the chip injection, and so wire position is confirmed also true or not, and so after that that's a little bit pull back to the so tight region at the so distal of RCA, and so rendezvous technique is also one choice.
So you mean to retrieve the retrograde microcatheter and do a tip-in or rendezvous in the yeah?
Yeah.
There is a chance to do that, right, Manus? Theoretically, if you retrieve your retrograde guide microcatheter a little bit and then try to tip in, make a rendezvous.
We could.
Yeah. Would solve a lot of problems.
We took it out now. And that's awfully refined approach, I guess, but yeah, I guess theoretically. But my concern is probably too much space there to make it work, but I mean, you never know. All right, so this is now, we went a little bigger.
At least you have a lot of options, which is good and
go up there.
Quite good in this scenario.
Then, see if we get that. Okay, let's inflate the balloon again.
Maybe, maybe a little bit. Maybe you have to retrieve a little bit your micro. I don't know.
Yeah, no, I agree. It's going in the wrong space there.
Yeah, it might be that your intra-plaque retrograde and some extra plaque antegrade. You know.
So I think what we'll do next, if you guys agree, is I think what someone proposed just a second ago, maybe do an IVUS antegrade. I mean, understand the situation a little bit better.
Yes, I think antegrade IVUS would also be very educational.
Because typically bigger balloons do it, but here we clearly have an issue. So, all right, let's do this. Let's get the IVUS antegrade.
Yeah, that we understand a little bit more why we are in a failure mode here. For the reverse card. It could be theoretically that extra antegrade wires extra plaque or vice versa. So we have to understand.
Yeah, I mean theoretically, based on the movement, my at least idea was that the antegrade wire is intraplaque there, and the retrograde is definitely intraplaque in the middle part because it went there very easily.
Yeah.
But I mean, you never know.
No, well, thank you for your great job here. Really, no, I see also the time. It's 7 p.m. in the U.S., right? So thanks to the team, to all of you.
Is it live?
No, this is perfect. Actually, we had the backup case. We did it before and almost didn't finish on time. So we're all primed up, ready to go.
Yeah, it's recording.
Okay, let's record.
Yeah, recording.
Very interesting here, right?
So the wire is intraplaque. I mean, you can see the wire is right next to our IVUS catheter. Yeah. And I'm coming back. And then there is calcium there.
There you are. Yeah.
Okay, stop recording. And let's play this back again. So interesting. So if I understand this correctly, and we'll look at this again, we are definitely in the same space. We're intraplaque with both. The IVUS is intraplaque, and the retrograde wire you see up at 11 o'clock, that wire is intraplaque. So we're in the same space. So we just have to find different wires. Just give me actually Mongo.
So Manus, so the easiest way would be now to inch grow the guide liner, right?
The challenge is guideline doesn't go. That's my challenge so far.
And then everything is easy, right? Should be easy, right? If you inch grow the guide liner over the curve,
there you go.
Got it. To the part where both wires were intraplaque, then a normal wire should just pass. Every wire should just pass into the guide liner. Agree?
Yeah, absolutely. You know, as you know, we've been trying to do this for a long time, and now finally it's the first time actually the wire seem to go. So now we should be
the proximal part of the guide wire
better
go to the subintimal.
Exactly,
Yeah.
exactly. So if we can
yeah.
bring the,
More
exactly. If you
dilate
can
more distally
Yeah.
and advance the guide liner.
Exactly,
Yeah.
exactly.
To the true lumen.
Yeah. So
Okay. Now
maybe even a little bit more. I don't know, but
he
maybe,
could advance the.
Manus, maybe you even have to advance it a little bit more.
Oh, yeah.
We didn't see the simultaneous the angio, but I suppose that that the guideliner has to be inch-grown a little bit more even. Because at this place there, you're deviating extra.
Probably the balloon there too. But I think I'm going to a different vessel or somewhere else. You're right.
Exactly. So if you can inch-grow it a little bit more towards your retrograde microcatheter, I think you should be in the same space. Agree?
Yeah.
Great. Yeah. But very useful to have seen the IVUS, because now we understand better what to do in terms of the reconnection. I think it was worth to invest that, right? Time for the IVUS.
Yeah, absolutely. I mean, we have the IVUS on the table, as you said, and you don't lose anything. Now, typically, most of the time, a bigger balloon works, but sometimes it does not, as in this case. So it's good to have, the more options you have, the better it is.
Yeah.
Okay, let's inflate there. And down.
2.5 balloon?
2.5, yes.
2.5.
So very good.
Okay, that should be
Yeah.
okay.
So guide enough to advance.
Of course. No, we'll go into the marginal, of course, now, but anyway.
Maybe you don't need a stiff wire here.
Yeah, no,
No, this is a Mongo.
Okay. Great. So very nice, Manus. Fantastic.
Let's bring it back.
That was important, I think, for many
try.
people in the auditorium here to understand as well that the IVUS can make sense in the reverse cart here once you're in failure mode. So I think it was a great demonstration to see that.
R350.
Yeah, to be honest, I think here sometimes we get fooled. I thought I was so close. I thought it would have worked 10 minutes ago, but oh well.
One goes out.
So we are at 0.7 gray, 30 minutes of fluoro, 4,000 DAP. So actually doing okay on the radiation thing. So I guess we'll see how the RCA looks like. But what is the panel thinking? Should we fix the rest? Should we fix the OM too? Or whatever is that other vessel, or stage it? What would you do?
Maybe I can answer this, because now you have if you open those both vessels, probably just watch the lady how she's doing. Residual syntax score might be even lower and not too high. So the question is, which data do we have for here to be really 100% sure that there might be a prognostic benefit to treat additionally this very complex intermediate branch. So taking that into account, probably, let's say, follow up the lady clinically would be reasonable. And I think in terms of data we have, do you agree?
Yeah, that's a good point. I mean, to be honest, it is a complex one. It is a complex procedure, as you've said. We have to make sure clarify the ambiguity. And also, if he's completely symptom-free, it may be hard to tell what is going on.
I mean, for sure, there are some clear trends that a complete revasc is superior in all the registries compared to a non-complete revascularization. So probably we have also to understand, what I probably would do is just to make an IVUS in the circ to understand where is the takeoff, how does it look like, just to plan the procedure. So I mean, just to have a better idea, it might end up directly in between the left main bifurcation, and that would be complex to treat. So to answer this question, probably one IVUS to the circ would be as well reasonable to better understand the takeoff of the cap. And then you can still...
Let's do this. Let's bring the guide extension back.
You could still decide. I mean, we have to take a little bit the complexity as well into account in terms of risk as well. It is feasible to open that vessel, definitely. There is a nice epicardial retrograde. There is we have to understand antegrade cup for that as well. I would favor complete revasc, but maybe if in a second step. But if she says I'm completely symptom free, so probably also she would be doing fine with the LED and the RCA.
Perfect.
After recognized the RCA, the patient the single vessel disease, CTO.
Yeah.
So one is medication is a good option. But if we try to OM, CTO, maybe the bifurcation stent needed. So the prognosis.
Okay, let's get the IVUS and see what's going on.
I think it's not good. So the other option is just a DCB after CTO treatment. If the patient has a severe symptom after this procedure.
Yeah, so...
Let's get the balloon again. Let's get the 2.5 balloon. Let's hit it again, take a picture. So I don't know if you saw this. We had some difficulty feeding our equipment, so we used the guide extension to externalize, to get the externalization wire out of the guide. And now we'll do an IVUS again, see what's going on distally. That distal RCA is still confusing to us about what is the situation. Okay, so it's not right here, so let's get this in. To put a...
So we have still some 7 to 8 minutes to go, Manus, and yeah, it would be great if we could have the chance to see the IVUS.
Perfect.
Also for the distal to decide how we treat the distality.
Yeah, so would you take a picture now, plan to do IVUS, but just curious what your thoughts are. Would you do that, or would you just take a picture? What would you do at this stage when we're across?
Well, you know, I mean, the intraplaque segment of the CTO probably I would have treated for sure with a stent. At the distal, as you know, we have the opportunity in Europe with the DCP, so
that's right.
That would be a good option for this young patient with 33 years old, right?
Yeah, and actually we do have the peripheral DCB. There is the Ranger Boston the scientific DCB that is 4x40, so it's a little big. I'm a little worried putting it in there.
Yeah.
But that might be a possibility. We have an 8 friends guide, so it will be compatible with that guide.
That would be great, because I mean, you know, you have to find a concept for the next 35 years, right?
Record?
Or 40 years. I mean, so therefore the full metal jacket should be definitely avoided somehow.
Looks good. Can you finish up here?
Well, actually, this, well, we don't see where you are because we don't see the simultaneous.
So we're now in the distal RCA there, where there's the there's some calcium there, some disease, diffuse disease. I'm coming back. Okay, we're still intraplaque, all the way there. The vessel is about what, 1, 2, 3, 3.5 probably there, media to media. Coming further back, this is the area of crossing. I don't know. Oh, there you go. Probably extra plaque, maybe for a brief segment there. But otherwise, we're good.
Yeah.
So I'm thinking, how about the 3048 synergy?
These vessels often dilate after proximal stenting, so we expect dilation at the follow-up in this patient at the distal side.
Yeah, so distal vessel looks reasonably okay.
Not too much there. This side has a plaque. There's some part of the shrinkage.
Yeah, but not too much distal plaque, not too much disease.
Let's do the normalized.
Yeah, so it's interesting also, the patient had some transient ST elevation while we were retrograde, but his pressure was like 180. So we gave him, put him on a nitro drip, and that really calmed him down. Pressure is good, the EKG is good. So sometimes patients get nervous or may get some discomfort from the retrograde gear being in place, but again, with injection of nitro, he's doing okay. Okay, give us the 338. 338. Yeah. So we're putting we're planning to use a 48, but we'll have out of the 48, so we'll use a 38. I don't know, I think you have even longer stents, right, in Korea and in Europe than 48, which is the longest one we have in the United States right now.
It's a 3.5 or 3.0? Or?
It's a 3.0, short post dilate with a 3.5. The media to media was like 3.5, so we'll downsize a little bit on that. This looks like a small vessel, so I want to make sure I don't dissect, especially distally. And then for more proximally, we can definitely do some more post-dilatation. But actually, I'm glad. I think I was extra plaque on the undergrade wire. You know, the way it was behaving, because I didn't have any issue with anything else crossing. So I think I was probably extra plaque, and the IBUS didn't show anything on the undergrade. So I'm glad we ended up using retrograde. So
yeah. You were extra plaque and then re-entered.
Ready for a little puff? Let's clear the guy. Yeah. So I think the externalization makes it a little extra clean there. Get a little puff there. Ready? Actually, one second. Tiny. Yeah. That was not the right thing to do, I guess, here. But anyway, we dissect a little bit the vessel, but we'll make sure it will come out. Okay. Give me a puff there. Puff again. Deploy.
Going up.
It's good, huh? Okay. Yeah.
Right, and let's go down.
14.
Okay, go up there. So we'll try to take a picture there, see how we look. Sometimes we have an ostial flask balloon, which helps you dilate the ostial parts of the stent so that you have an easier time re-engaging, because here I think we went all the way into the aorta.
Okay.
Okay, and let's take a picture here, see what we got. Actually, let's give a little nitro. Let's give 200 of nitro, and then actually, no, wait a minute. Are we giving IC nitro still?
Yeah. It's going.
We are, okay, we're good then. Let's take a picture. We'll puff, make sure we're filled. Okay, not engaged yet. Tiny little puff there. Okay, picture.
Yeah, very nice.
Okay, so you can see the proximal, the distal vessel is indeed very diffusely diseased. My feeling is to leave it alone.
Yeah.
But I'm curious on your thoughts. I think it's just going to grow probably if you leave it, give it some time, and it's going to get better on its own.
It's reasonable. 43 years, timid-free flow, long disease, reasonable to leave it alone or DCB it. So I think you can leave it alone, honestly. Huh? Satoru, what do you think?
Yeah, I don't want to put a 4-0 DCB here. You know, in the US, we don't have that.
But you think there's a downside to leave it?
Yeah.
Like that?
Let's get a 3-0
Would you put stents in it?
No.
No stents. Okay. Yeah. Me neither.
Let's get the IBUS in the meantime.
Meanwhile, I want to follow up clinically.
Yeah. Okay, Manus, we are now at the end of our time. Maybe you want to summarize, wrap up the case, or
Yeah, absolutely. So thanks again for having us participate. We're grateful for spending the time with you. Thanks for your suggestions. Just to summarize, we had here a young patient, 43-year-old, with essentially multi-vessel coronary artery disease. The target vessel was the RCA CTO, significant disease in the LAD, proximal LAD, so we decided to stent it before going retrograde because there was an ambiguous proximal cap. The retrograde, as you saw, septal, were able to cross with the SU03, and then we had some difficulty making the connection. Some balloon uncrossable on the undergrade side, so we had to use different things. Sapphire didn't work, multiple balloons didn't work, trap liner didn't work, but eventually a turnpike spiral worked all the way down. Then we were able to get the inch-warming of the trap liner all the way to the mid-RCA. We did the connection in the mid-RCA, externalized, stented the most diseased part of the vessel, going to leave the rest, and got a nice result. And then I think we're going to leave, as you suggested, we're going to leave the other CTO vessel for the time being and see how he responds to the current recanalization.
So thank you very much, Manus, to your whole team. Great job, fantastic case. Thanks a lot. So we are ready to close the session.